So welcome everyone. It's quite odd, these Zoom sessions, when you're speaking into a void and you know that there's some 200 people on the other side of it. So I hope you've all had a good day and thank you very much for attending this evening. We've got the first in a two-part series, our annual Shared Maternity Care Collaborative Workshop, which is a collaboration between the Royal Women's Hospital, Western Health, Northern Health and Mercy Health. My name's Ines Rio, I'm a GP. I also run the GP Liaison Unit at the Royal Women's Hospital, and I have the pleasure of working there in antenatal sessions under Vicky's leadership, and that happened today as well. I'd also like to welcome two colleagues from the General Practice Liaison Unit at Western Health, Jo Silver, who's the Director of the unit, and Karen Aarons, who works there as a GP Integration Liaison Officer. So I'd start off, I, along with North Western Melbourne Primary Health Network, the Royal Women's Hospital, Mercy Health, Western Health and Northern Health, would like to acknowledge the traditional custodians of the land on which our work takes place, which will be different lands for different peoples at the moment. But for me, it's the Wurundjeri Woi Wurrung people, the Bun Wurrung people and the Wathaurong people. We pay respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. So a bit of housekeeping. All attendees are muted. Please ask questions via the Q&A box only. I'll actually be raising those questions right through the presentation and then at the end of the presentation. Vicky will be going first and then Rachel. The session's being recorded. When I ask questions, I'll be asking only by people's first names in order to protect their privacy. Please ensure that you'd actually join the session using your name, as that's how you'll be ticked off with regards to your CPD. And you'll actually get an attendance certificate in the next, I think, few days. If you're not sure if your name matches, please send a private chat message to NWMPHN Education in the chat function to identify yourself and just link the name that you actually have on screen to your name that you've registered with for CPD points. There was a link to an evaluation at the end of the session in the chat. In approximately a week time, you'll receive a PowerPoint and a link to the recording. For this session, you'll receive 4 RACGP points that are pregnancy related, and that evidence will be on your CPD statement in about a month. Next week, we have part 2 of the Shared Maternity Care Collaborative Annual Workshop. That's also eligible for an additional 4 pregnancy related points and runs at the same time next Wednesday. And that's on GDM, gestational diabetes, and third trimester. Actually, I've written third trimester issues. That's not the case. It's actually high and low body mass index in pregnancy. Re-credentialing for GPs at the Women's Mercy, Western and Northern Health will be coming up at the end of the year. It's being led by Northern Health and will be via a tri-booking system, so fairly similar to the last triennium. There's a 2-step process. In about a week's time, in late October, you'll receive an email asking you to register. You need to register with tri-bookings, and then after that you can actually upload your documents, which actually include evidence of medical indemnity, agreement to undertakings, and 5 hours of pregnancy-related CPD points. Queries on the process, timelines and application, please contact the Northern. If you have queries about whether your CPD points or the activities you've undertaken are sufficient, we have a CPD list that's available on both the women's site, and I think it's on the Western site too, isn't it, Jo? Yeah, and it's a women's site, it's under health professionals, then you go to GPs and GP CPD. So you can see there's a number of activities that tells you how many points that were allocated for pregnancy related points. but feel free to email me if you have queries about CPD, whether your CPD points are sufficient after checking that table. And I know Jo takes many of those queries as well. I just wanted to introduce you to Health Pathways. I imagine many of you know about Health Pathways, but Health Pathways Melbourne provides clinicians with a single access point to assist care in the community, referral pathways and resources. It's free to all clinicians, but you do need to register. And there are a number of very relevant issues that are covered tonight. They're written by GP clinical editors with support from local GPs and hospital-based specialists and other subject matter experts. Relevant pathways that exist in Health Pathways are antenatal, second and third trimester concerns, COVID-19 positive management, referrals, vaccinations, and medicine in COVID-19. So there's some of the sorts of issues that you will find and some of the assistance you will find in Health Pathways. And, as a GP, it's very useful because you can look up things like dementia screening, falls, pregnancy care, care for hepatitis C, the whole gamut of management and treatment. So now introducing our two speakers for this evening. Thank you very much for attending. Dr. Vicky Wood, oops, sorry. I've just got rid of my screen. Please excuse me. It's all going so well here. I'll just flick to the back, to the bottom. Excuse me. Dr. Vicky Woodward is a general obstetrician with an interest in high-risk obstetrics. She works privately at Francis Perry House and is the leader of Yellow Maternity Care at the Royal Hospital. She has a strong interest in Indigenous women's health and women with previous birth trauma. Recently, Vicky was tasked with setting up the COVID-19 ward at the Royal Women's and enjoys the team environment that comes with such initiatives. She also currently is chair of the senior medical staff at the Women's. I'll also introduce Rachel at the moment. Rachel is a general obstetrician and gynaecologist who divides her time between leading the Green Antenatal Care Unit for Women's and her private practice. She's been working at Royal Women's for more than 2 decades and continues to enjoy the collaborative nature of the hospital environment and the diverse women that it cares for. Areas of interest include high and low risk pregnancies, general and laparoscopic gynaecology, colposcopy, PCOS and menopause. So thank you very much, Vicky and Rachel, and over to you, Vicky.
Thank you so much, Ines. I will just share my screen and get my presentation up. I'm going to apologise for the look of me on the screen. I'm battling with some sun coming in as the sun sets, and so it's sort of going to be all over my face at various times, so I apologise in advance. So let me get this up and running. Ines spoke to me a little while ago about doing this talk, and she said, can you talk about COVID? And I spoke to Ines a couple of weeks ago and said, COVID's actually really boring now, so there's not a lot to talk about. So I'm going to run through a whole bunch of things quickly that you may see in some of the pregnant patients that turn up at your practices, and just to kind of update you, show you how you might link in with policies with the various hospitals that you might be working with. So we'll get started. So I won't introduce myself again. Ines has already done that, and thank you, Ines, that was very nice of you. So we're going to talk briefly about COVID. How did we get here, and do we actually need to worry about it anymore? Parvovirus, what I like to call the triennial visitor. It seems to pop up every 3 years in an epidemic. Hand, foot and mouth disease, the childcare favourite. Varicella, the one that everybody worries about, chickenpox. And CMV, which I like to think of as the confusing one. It confuses me. I don't know about anybody else. So as you all know, well better than me, and I feel a bit silly talking to GPs about COVID because, golly gosh, you guys have been on the front line of managing not just COVID, but the policy changes that came with it. So as you know, it started with the Wuhan variant, and that very rapidly morphed into the Alpha, the Beta and the Gamma variants. But then we really got hit with a sucker punch as Delta came through. And Delta was the one that had caused all the trouble really in the hospitals. And that was the one that really had us on our toes at the Royal Women's, and we'll talk a little bit about that in a minute. And that was the one where we really started to actually see the pregnancy complications coming through. And now we're sitting in the land of Omicron. And again, that's been a little bit different. And we'll talk about those, some of the changes we've seen with Omicron as well. So as you may know, the government has a dashboard for COVID in Australia, and everybody can look at that, and it gives you a sort of state of play of where we're at with COVID at any given time. And since the beginning, the first notification of diseases in Australia, we've had over 10 million cases, which is staggering, really. And more staggering, I think, and sad is that we've had 14,853 direct deaths from COVID. So that clearly doesn't take into account anybody who died of other things, waiting because they couldn't get into hospital because of COVID and various other things. So it is a serious disease, and it's serious for our pregnant patients. And there were a number of what were called living systematic reviews published, which is basically a study that's done on the review, a review that's done on the run, looking at pulling in as many studies as they can really quickly. And it showed that about 9 to 10% of pregnant or recently pregnant women have had COVID in their pregnancies or around the time of birth. So it's not an insignificant number of women that we're seeing that have exposure to an infection with COVID during pregnancy. So at the Royal Women's, we started as what was called a streaming service. So that meant that we received COVID positive women from particular referral sources. But then in October 2021, we were asked to stand up a COVID ward, which was a very interesting experience. So we turned our antenatal ward in the space of 2 weeks over to a COVID ward. I learned that you can't ask for a PowerPoint in the hospital or an ultrasound for breech presentation, hey, Rachel, and get it in less than a year, but you can make a COVID ward and build an airlock in 2 weeks if you really need one. So alongside Monash Medical Centre, the Royal Women's became one of the two big centres for sick COVID positive pregnant women. I think Joan Kerner was certainly taking well and truly their fair share as well at the time. But we set up an entire COVID ward, the full airlock, full donning and doffing when you left, and when you came in and when you left. And we had the sickest of our patients were in the intensive care at Royal Melbourne, but they were certainly under the care of the Royal Women's consultants. And it was a really new era for us, and someone described it as learning to fly while you're still building the aeroplane, and it really was very much like that. I'm pleased to say the COVID ward is now officially disbanded. We do still have airlocked rooms and negative pressure rooms, and we are still using them for COVID positive patients, but they're well, and they're really isolated because they have COVID, and they haven't really caused any trouble for us in terms of needing extra medical care. We haven't had a patient in intensive care with COVID for months and months and months. We haven't seen sick COVID patients on the ward for months and months. And whereas back in the bad old days, we were not allowing partners to attend a caesarean section if the pregnant woman had COVID, which was pretty awful for those of us who were involved with those caesarean sections. We now are able to bring those partners in, and the partners are now seeing them through and spending a bit of time with them postnatally. So it's become much more normal for us at the Women's. So why do we care about COVID in pregnancy? We had lots of studies published as Delta ripped through the world, and we knew that women who got COVID in pregnancy did end up sicker, and potentially that's partly because of the differences in lung physiology in pregnancy. So we know that women with influenza get sicker, and we saw the same sort of thing happening with some of our COVID patients. Interestingly, the two living systematic reviews commented that women seem to have less of the simple symptoms of COVID. So they'd get less fever and cough and malaise, although, you know, a third of women still get those symptoms. We know that women who got COVID in the time of Delta were much more likely to end up in intensive care than their non-pregnant peers, and more likely to be ventilated. And we're talking odds ratios of 6 to 8. And they had an increased risk of preterm birth, IUGR, and stillbirth. But Omicron is vastly different. Now, keeping in mind, we also have a vastly different population of women who've been vaccinated compared to what we had at the beginning when Delta was really starting to cause trouble. We know that Omicron's more transmissible, but it is less virulent. Thankfully, because it also isn't super well covered by the original vaccines that we had. We saw with Delta, and it took us a little while to work this out, the women who were presenting with, sadly, often with decreased fetal movements, and we certainly had a couple of cases at women's where those women were discharged because everything was normal, and then we saw them represent with stillbirths. And what we were able to demonstrate is that you can actually do a particular kind of staining on the placenta, and it looks for a histiocytosis. And so we were seeing an inflammation or a placentitis, so an inflammation in the placenta. And I'm pleased to say, again, we haven't seen that as Omicron has become the predominant variant in the community. We just have not seen the placentitis coming through that we did. And we certainly don't see it in women who are triple vaccinated. And there is a difference in that rate between women who are double and triple vaccinated. So we're much more confident, much happier about perinatal outcomes now. And also with that reduction in seeing that placental inflammation, you may recall that we were suggesting that women who'd had COVID should all have a growth scan about 2 weeks after their COVID infection. And we're really keen to discourage that from being a routine part of practice now, because certainly we can't keep up with it at the women's, and we're not seeing the same placentitis, so we're not seeing that growth restriction. So if women are mildly unwell, and the stay-at-home level we're talking about, and vaccinated, there's no need for a growth scan following COVID infection, unless there is another indication for growth scan that you would normally organise that. So really simple, what to do with COVID positive pregnant women, not vastly different from what you do with anybody else who's COVID positive anymore. It is important to get a story about what to do about where they're at with their vaccination status. So again, slightly less important with Omicron, but certainly we know that women who'd had 2 vaccinations and were more than 6 months post second vaccination were basically behaving like they were unvaccinated. And so we were super keen, and remain super keen, to encourage women to be vaccinated, but certainly to have triple vaccination. And the jump in cover or change in how much benefit women get from the 3rd to the 4th vaccination is minimal. We do know that there is transplacental crossing of antibodies if women are vaccinated while they're pregnant, and that probably does give some protection to the baby, and I'll talk about that in a second. It's important to determine the severity of illness. Most women that you speak to are going to be mildly affected with cough, malaise, runny nose, sore throat, etc. But if they're more severe than that, we obviously need to start thinking about where they should be cared for, and what monitoring we're putting in place. Important to know how many weeks pregnant they are. Are they just carrying a singleton or a multiple pregnancy, and do they have other medical problems? We're still encouraging women to register. There's a bit of a couple of patients I've spoken to lately, like, what's the point of registering? Well, the point of registering when you're pregnant is you can actually still get sick, and it is handy to be in the system. But we can be generally very reassuring for women that there's usually a very benign course for them and their baby. We'd strongly encourage them to rest and do all the good symptomatic things, because none of us are really sure about who gets long COVID and why they get it. So, it is important to rest. I think there's some thought that people who sort of push on through COVID are more likely to end up with problems long term. So I think asking them to rest as they would or should with any other virus. Explain how to monitor for worsening wellbeing, and that's really shortness of breath, tachypnea, fevers that aren't coming down after 4 or 5 days. The most important thing that we want to emphasise from their home hospitals is that we really want them to continue their usual pregnancy care for things that might prompt an unusual visit. So, for example, reduced fetal movements, antepartum hemorrhage, threatened prem labour, they still need to be seen for that. And it was one of the big messages we really worked hard to get out when we were seriously locked down and not allowing partners in the hospital, that you still need to come to hospital for those things. So all of the hospitals have very good protocols in place for how to bring a COVID positive patient into the hospital and how they're seen, and all of the usual things, CTGs and ultrasounds and examinations can all occur. And the bad stuff happens when people sit at home and ignore and don't come in. We've got increasing evidence of safety of the medications that are used in COVID in pregnancy, but as you will know, far better than I do, that less useful as the variant is now different. And we from the Royal Women certainly can reassure people about their care. The care around the time of birth is essentially pretty normal. I mean, we're all in PPE and they're in a COVID room, but partners can be in attendance. We can use gas even if you're COVID positive. Your baby can stay with you. You can do delayed cord clamping. So none of that should change. This is, you don't really need to know this, but the women's, actually, I'm going to apologise for anybody who's doing shared care at the women's, because I know in trying to do this talk, I tried to find our guidelines for COVID and I haven't helped write them. I know they exist, but they're actually inaccessible on our intranet or for clinicians at the moment. So I'm really sorry that they're not available. There's a new guideline software system going up, and so they've just dropped off that for the time being. Basically, really in terms of severity, it really comes down to respiratory rate and saturation. So anybody who's needing oxygen is moderate or severe by their very nature. In terms of vaccinations, I'm sure everybody online knows this. There's increasing evidence now as the time goes by of safety of COVID vaccinations in any stage of the pregnancy. As I said before, there is a large improvement in outcomes going from the second to the third dose. And perinatal outcomes are different if women are not vaccinated. It's one of the things I always like to remind my patients is when we talk about the baby having protection against COVID because you were vaccinated during pregnancy, it's not because the baby has got COVID. It's because the antibodies were transplacentally, transmitted. So that's just something we often, once I've explained that to patients, they're much more comfortable about having the vaccine. The fourth dose is safe in pregnancy. It probably will give some protection to the baby due to those transplacental antibodies going across. But as I said before, and Ines and I were just talking before, that certainly the advice I'm giving to my patients, and I believe it's been backed up by ATAGI, is that the increase in benefit to pregnant women is not as huge as the second to third dose leap, but the third to fourth dose is not as huge. And as you'll know, pregnancy in and of itself, it's one of the most common questions I get, is not an eligibility criteria. So over 30 years, but and other medical conditions, immunosuppressed, et cetera, et cetera. So just because you're pregnant doesn't make you eligible for the fourth vaccine. Symptomatic management remains reasonably unchanged: codeine and Folcatine for the cough, paracetamol for fever, shortness of breath, just remembering to exclude other things, so worsening or exacerbation of asthma, pulmonary embolus. Investigate pain if concerned. It's not, none of this is rocket science, and it's all very straightforward. The data from the living systematic reviews and various studies throughout, particularly the Northern Hemisphere, have given us really good indications for who are the women that are pregnant that get COVID that raise more concern for us. And they're the women who are of advanced maternal age, and that's typically in the literature considered 41. Why 41 and not 40, I'll never understand, but it just is. High BMI, chronic hypertension, pre-existing or very early onset severe diabetes, gestational diabetes or pre-existing diabetes. So essentially that early onset severe GDM is those ones that you think are actually unmasked type 2s. Preeclampsia, and obviously all the other medical comorbidities that we're seeing more and more in pregnancy.
Thank you. Vicky, just a question from Kath. We might not know the answer, but do we know what happens with the fetal antibody over time?
We don't, and it's a great question. So, we know it decreases. We know that. And we don't know what period of time we get out of that. So as you all know, we sort of tell people that with whooping cough vaccine, they'll get 2 to 3 months protection for their babies with that. And with the flu vaccine, they get about 6 months protection for their babies postnatally. So we do know that vaccinations have varying time periods where the babies will benefit from those antibodies. And what we don't know is what is it with COVID.
Thank you.
This is nothing. This is a slide from the women's guidelines, just to show that they exist, but also just to really point out that in terms of giving COVID-specific medications, really, if you are symptomatic and you don't require oxygen, and you are well, you do not qualify for medication. So if you have multiple risk factors, they recommend giving an inhaler for particularly if they're within 7 days of their symptoms and are either immunosuppressed or not fully vaccinated and have medical criteria, then you would consider sotrovimab or Ronapreve. But you can sort of see you have to be unwell enough to come into hospital, but perhaps not on oxygen within the first 7 days of your illness, not fully vaccinated, and one of those things before we would even consider medication.
And just for the GP's sakes, there's also on health pathways, there's the information on medication in pregnancy and medication generally. But the other thing that I've found very valuable is the Alfred statewide phone number, which I'm not sure if you've got in here, but certainly is on the health pathways. And that's really valuable if you're getting into that, you know, should I give somebody medication? What medication should I give them? And that's been very helpful. Thank you.
So it's pretty, I haven't got that number on Ines, but yes, you're absolutely right. That's a great number. And also it's pretty unlikely that you will need to start medication, because I think if you're getting to that point where even if they're not requiring oxygen, certainly most of the large maternity hospitals would be thinking about bringing that woman in for observation at that point anyway, because they're getting pretty close at that stage to oxygen. And once we get to the oxygen stage, we're then starting to think about, should we be giving some steroids or something to reduce the inflammation of COVID? And you can give that orally, yes, you can, but you know, I think most of us would err on the side of caution and bring that woman in and give IV dexamethasone. And it really, it gets a bit nitty gritty here, because it will depend on how many weeks pregnant they are, and whether you're going, you know, entertaining delivery, and there's a whole bunch of other things that come into it. So I think really that certainly at the women's, our MFM fellows take phone calls about COVID positive pregnant patients very happily, and are extremely experienced, having run the COVID, you know, worked with us with the COVID ward and the sick COVID patients. But they also ran all our outpatients who had COVID, and that was a huge job at the time. So they're very, very good. So just pick up the phone and call.
So take-home message is, if they're significantly unwell, then ring up and get advice from the women's.
Absolutely, absolutely. And the medications are all there. I'm not going to go through them because you don't really need to know them. But the ones that we have used with Delta are not quite as relevant nowadays with Omicron, to be honest. The budesonide inhalers probably do make a difference, and they're obviously something that's simple and easy to use at home.
And when you're talking about a woman being admitted and becoming unwell and requiring sort of more intensive management, is it really about maternal illness and fetal and baby illness, or really about maternal illness?
It's about maternal illness. So that's the real risk. We obviously, like we would with any woman who's in intensive care for any other reason, do keep an eye on fetal well-being. But the concern with COVID is maternal illness. And as I say, the beauty of the times we're in at the moment is that we're just not seeing that. So we just are not seeing unwell women at all. And it does make you reflect on the time when we did see so many sick women, and they were really, really sick with Delta. And I'm sure Rachel will agree, she will have done ward service at the same time as I did. And we really saw very sick women over it, particularly in the Royal Melbourne ICU. And so all of the medications we were giving at that time were directed towards improving maternal lung function, essentially. So reducing inflammation is really as good as you can do. And this is just a reminder again, a little bit, just to remind everybody that clots are much more common in women who've had COVID, and they're more common in pregnant women as well. And so in thinking of venous thromboembolus in COVID patients, this is again from the Royal Women's. So basically, if you're pretty mild symptoms and you're at home and you don't have any, apart from being pregnant, no other risk factors for a DVT, then we do not give anything. But once people start to get into any situation that might immobilise them, then yes, we would consider it. So that's second line. So pregnant, self-isolating at home, mild, but with additional factors. So large BMI, recently had an emergency Caesar. I would be ringing and asking for advice again from the MFM fellows about that. And we do send patients who've been in, who have been COVID positive, we do send them home with slightly prolonged anticoagulant use. So for COVID, the take-home messages are vaccination is safe. It definitely improves the maternal and fetal outcomes. Thankfully, placentitis that we had been seeing associated with stillbirth and growth restriction and reduced movements is rare with the Omicron variant. We don't know what's around the corner with the next variant, so just keep in mind that it might all pop back up again. We can at the moment reassure women about outcomes and the course of their illness. We do still need to keep a close eye on those higher risk groups of women, and we would encourage women to come into the hospitals for the things that they would normally come into hospitals for, and not put it off because they've got COVID. Vaginal birth, delayed cord clamping, skin and breastfeeding is still all okay. That is essentially all I have to say on COVID, because, you know, it is thankfully less and less of an issue for us. We're just not seeing sick women, and we're not seeing things of great concern. All right, Ines, did you want to ask a question? I could see you.
No, I think we've probably pretty much answered all the questions. If people have questions, please just pop them in the Q&A and I'll just keep asking them as they arise. Thank you.
Beautiful. All right, well, I'll move on to parvo, which, as you will all know, seems to pop up in autumn and spring in Melbourne. We don't know why, but that is what the data will tell us. And about every 3 years. Now, we haven't had an outbreak for a while because we've had nobody in childcare for a while. I would imagine that that means we must be coming up for a doozy of a parvo season at some stage. So parvovirus B19, all my patients say, isn't that the one that dogs get kennel cough from? No, it's not. It's ever so slightly different, but it causes slapped cheek disease in humans. We know that 60% of Australian adults are immune, and so we know that that means that 40% of our pregnant population are actually susceptible. If you're caring for someone at home or someone at home has parvo, you've got a 50% chance, and you're susceptible, you have a 50% chance of getting it. If you're a teacher or a childcare worker and you're non-immune and someone in the room has it, there's about a 30% chance you'll get it. If you do get it while you're pregnant, there is a 50% chance that you will give it to your baby. So we talk about mums being infected, we talk about babies being infected, and that's that 50-50. And then we talk about babies being affected. And so if you get parvo in the first 20 weeks of your pregnancy, and I would argue probably in the first 15 weeks is probably more practical, there's about a 10% excess fetal loss rate over and above what occurs for the number of weeks pregnant you are. And about a 3% chance of the fetus developing hydrops if you get it early. It can cause, as you know, fetal anemia and hydrops. There is no correlation between how unwell mums are and how unwell babies become. So in fact, most mums, it's a bit of a nothing illness really for them, maybe a cough, a mild runny nose or a sore throat, but really not much. And the hydrops develops after the baby's been infected and then has its bone marrow suppression. And then, so it's the number of weeks after the maternal infection that you'll see the hydrops evolve. And the average is 5, but you can see there in what I've written there, it's anywhere between 2 weeks and 17 weeks. So of the babies who did develop hydrops, a third will just get better on their own. The virus clears and they get better on their own. It's incredible. A third will die before we can get a transfusion into them. So we see the hydrops, we do everything we want to do, and we're just within that very short space of time, the baby's died by the time you get the next scan on them. And a third will get to a intrauterine transfusion, have it, and actually improve and resolve. So as you know, parvovirus is serology. If it's positive IgG, mum's had it in the past, she's one of the 60%, you can reassure her. If it's a negative IgG and she's been exposed, we would recommend retesting in 2 weeks. And if she gets a negative IgM, retest in 2 weeks. If she has a positive IgM, we assume that she's been infected recently. If both positive IgG and IgM, that is a confirmation of infection. The IgM becomes positive within 1 to 3 weeks and it stays positive for 2 to 3 months. So once you've confirmed infection, the risk is fetal anemia, which then leads to the fetal hydrops. So we would recommend getting an ultrasound once a week for 10 weeks, and that's looking for hydrops, but also doing a middle cerebral artery peak systolic velocity measurement, which is then compared to norms. And believe it or not, it can detect increased systolic flow through the middle cerebral artery as a sign of fetal anemia, and it enables much cleverer doctors than me to do a fetal blood sample to confirm the anemia and the degree of anemia in the baby. And if they're going to do that, they'll set up for an intrauterine transfusion at the same time so that it can all be done in the one cord sample. The problem with intrauterine transfusions is there is about a 4 to 6% death rate, and particularly if you're already dealing with a hydropic baby. So that's parvo, and I always say to my patients, that's why we look for your I do parvo serology on all of my pregnant patients at the beginning of pregnancy, and working in private, I get to see what GPs order, and I would say there's about a 30% order rate for parvo.
Yeah.
I do it because I know I'm going to get the phone call in 5 weeks' time that little Joe has got parvo, and it is so reassuring to be able to say, I've got your results right here. You don't need to worry about it.
Yeah. So that was going to be my first question, Vicky. It's certainly not, it's supposed to be a universal test, but I know I, as a GP, tend to do it more targeted. If there's somebody who's a primary school teacher, a GP or a doctor, that sort of thing, I'll tend to do parvo early on. But that's interesting. I think we do vary somewhat.
So, Ines, would you do it routinely if people had a toddler at home? Because I guess the bigger risk of infection is in the home, actually, and so.
Yeah. It's interesting. I think I certainly, if somebody has a toddler at home, it would be interesting to talk about what you say with CMV. If they've got a toddler at home, I certainly ratchet up my discussion about sharing food and toothbrushes and saliva and the whole sort of, infection control if you've got another toddler or another child. But I must say that I personally don't do the parvo, IgG and IgM in that circumstance, but I'm sure that it does vary with people.
Yeah, absolutely. And look, it's an easy thing to do if they've had exposure.
Greg was asking, if you've got somebody who's 20 weeks and above, can you just flatly say, as long as you know that there's gestation of 20 weeks and they have got it at 20 weeks and beyond, not that you're actually measuring something that they had 3 or 4 weeks ago, can you confidently just reassure the woman and not do any further investigations? So
you're saying if someone seroconverts to parvovirus at 20 weeks or beyond?
Or is exposed to it at 20 weeks or beyond?
I would still treat them exactly the same. So even though there is a slightly different outcome in earlier pregnancy, they're more likely to lose the pregnancy. Later pregnancy, they still develop anemia and hydrops. So I would still, and in fact, you can't do an MCA PSV for fetal anemia earlier than about 18 weeks, but most of us would feel more comfortable from 20 weeks on. You absolutely must continue. If someone seroconverts to parvo at any stage in their pregnancy, you need to watch them for the next 10 weeks.
Okay, that's very useful. Now, I'm just going to ask a question from Rutika, just back to the COVID immunisation, because it wasn't asked before. And I don't think there's probably a black and white answer for this, but she's keen to know what the latest immunisation advice is for pregnant women who contract COVID early in the first trimester. They're 3 months post-infection and they're due for a booster. Would you be saying for that booster, especially if we're talking about the second or third, would you be saying get what you've got now or wait for the, the bivalent?
Get what you've got now. That's an easy one. So I would be saying get what you've got now. Vaccination is better than no vaccination, particularly if, as you say, if we're talking about the second or third, I think it's lay down misère.
Yeah, I was going to say, I thought it was going to be about the fourth, but it is. I think it's a lay down misère if it's second or third. Get yourself vaccinated, because after 3 immunisations, it's very unlikely to get severe disease.
That's exactly right. And I think we battle a little bit with, there's a bit of an urban myth out in the community that, well, if I've had COVID, it's a bit like getting a third vaccination. And I think it's really important to note, I've had a number of patients who've had repeat infections now. So it's not the same. I don't understand the physiology behind it, but I think you are better protected from a third dose of your vaccine than getting COVID seems to give you. So, and it, someone who's into vaccines will be able to explain that better than I am. But definitely, so people are saying, well, I've had my two vaccines and then I got COVID. So that's like having 3 vaccines, but it doesn't seem to give you the same protection as having 3 vaccines. So get the vaccine. And I've just got a few questions here. How do you know whether to check for parvo given how non-specific the illness can be? And I think that's a really hard question, actually. It is. And so, and I think CMV is a bit the same. We're going to talk about that in a minute. So how many times do you do the test during pregnancy and what symptoms do you jump on? So probably the biggest reason I would do a parvo serology is someone has come to me and said, oh, I saw my friend yesterday and she's just told me that little Jimmy has got flat cheek disease. Yeah. It's much more about the GP has seen the toddler 2 days later and said, oh, that's such cheek disease, that's parvo. And the poor old mum of the toddler has rung all of her pregnant patients that she's exposed.
Yeah, I've got a GP working in a respiratory clinic that asks whether they should have a low threshold for ordering parvo antibodies in pregnant women who've got a viral symptoms. I think the answer might be yes to that.
Yes, I think so.
Yeah.
So if you don't know that they're immune and or if you know that they're susceptible, because it is something we can monitor for, and if we pick up fetal anemia early, we can actually do something about it before the baby becomes hydropic. And that saves babies' lives. There are multiple documented cases of babies having intrauterine transfusions when they're anemic but not hydropic, and it's a transient illness in fetuses.
Yeah.
You nurse them through that anemia, they recover from the virus, their bone marrow recovers, and they go on to be okay.
And I suppose Lisa's getting to the crux of it in some ways, because in general practice, we often see the woman who has a mild rash, has urty symptoms, and she's pregnant. And then the question is, what do you order in that circumstance? And I'm not sure whether you're touching on that later, but I'll leave you for it. But, obviously parvovirus, CMV potentially. Is it toxo? Do you do your PCR swabs?
So toxo is a nightmare. So toxo results are really awful to interpret, as I've discovered recently with a poor old patient, and we frightened her. So toxo is one that's a bit like CMV, where you end up doing avidity because it's really difficult to work out when the infection occurred. And even speaking to Michelle Giles, who's our ID physician, even with avidity, toxo is really, really difficult to interpret. So I'm not saying don't do it. And my patient who was toxo positive didn't have a cat. So we really were scratching our heads, and it comes from far more than just having a cat, but it comes from raw meat essentially, or undercooked meat. So don't do it, but be prepared to pick up the phone and speak to an ID physician if you need to, because some of these results are really confusing.
And the IgM can hang around for absolute ages.
Exactly. Yeah.
Over to you. Thanks.
Sorry, this is Yvonne back in support. Can I just remind participants to put their questions into the Q&A and not the chat function, because Ines won't be looking at the chat function for your questions. So just remember, just in the Q&A. Thank you,
Yvonne. And the other thing is that I'm getting some questions in the Q&A that have already been answered, so I'm just closing those down. Thanks.
Thank you.
And there are some comments in them.
So hand, foot and mouth disease, the one that goes through childcare on a very regular basis. We've just had I don't know if Rachel's found this in private practice as well, but we've had a lot of hand, foot and mouth disease in the last few months. So the good news is hand, foot and mouth disease is, apart from being highly contagious and kids are miserable with it, and it makes you miserable because they're just hanging on you the whole time, it is no evidence of adverse pregnancy outcome. So we can really be very, very, very reassuring to mums. That's all I've got to say about hand, foot and mouth disease, because we don't need to worry about it. So chickenpox, if you're seeing women for a pre-pregnancy checkup, it is, I think it's behoving on us nowadays to test all women for their varicella status, just like we would for rubella, vaccinated, not immune, and give them, tell them not to get pregnant for a month. If you're seeing women for their first pregnancy visit, test all women as part of antenatal serology. If they're immune, nothing further to do. Non-immune, we advise them to report any possible exposure. If they're exposed, you repeat their serology. If you're seeing them within 96 hours and you know they've not had varicella before, they're not immune, Zig, as you know. But at the time of giving, and I should have put it on the slide, but at the time of giving Zig, that is a really good time to pick up the phone and talk to someone at one of the major hospitals. Because it does get complicated and they can get sick. If they're more than 96 hours before, we don't usually give Zig, and we consider a course of oral acyclovir. And again, the patient needs to know that if they get symptomatic chickenpox, they're at risk of lung disease, and so they need to stay in touch with us about their symptoms. So again, that's the point where you would pick up the phone and speak to one of the MFM fellows or an ID fellow at whichever hospital you're associated with, or a consultant. Because in women who go on then to develop chickenpox, most of us would like to start a course of oral acyclovir. But if you've just missed the boat, that little bit, most ID consultants are still going to start acyclovir, to be honest, although the guidelines say don't. Most of them will, because they're hoping for a little bit of benefit. But the big complications, as we said, are respiratory. They can get an awful hemorrhagic rash, and they can have prolonged fevers. And so we don't like to bring them into hospital because they've got chickenpox, and it just ends up exposing half of our pregnant patients to the same disease. So picking up the phone and speaking to an MFM fellow, an ID fellow, and then we can organise, well, where is the best place for those patients to go? And it's probably not going to be in a maternity hospital. As you know, the biggest risk of varicella is in the earlier part of pregnancy, or I should probably say in the middle part of pregnancy, that 12 to 20 weeks. If women do seroconvert to varicella and they don't, they get over the acute risk of chickenpox themselves, then we start worrying about the baby. And so that's regular fetal ultrasounds. You can do an amniocentesis for a PCR on the amniotic fluid. It's reassuring if it's negative. If it's positive, it's still very difficult to predict the outcomes for babies. The things that and they may not be apparent early in the ultrasound surveillance period, because what we're really looking often is a baby who's developed chickenpox, and then that chickenpox has caused skin scarring and limb abnormalities. So it often comes a long time after. So that's chickenpox. So it's a ZIG, acyclovir, and get some help. And CMV, routine antenatal testing, is controversial. Almost every conference I go to basically still says, please don't do routine antenatal testing for CMV. As you will know, there is an extremely vocal group of parents of babies who've been affected by CMV in Australia that are really, really pushing for antenatal testing for CMV to be standard practice. But the jury is out on the benefit and the interpretation of those results. So currently the best advice is to test if there's been a known exposure, a history suggestive of illness, and it comes back to what you were saying before, Ines. It's really hard because it's often a mild illness, and there are some patients who, due to their occupations and things, I've tested multiple times during their pregnancy. It's a bit frustrating for all of us, but there's no other way around it. And obviously, if there's abnormalities on ultrasound that might suggest an antenatal course of CMV, exposure to CMV, then we'd go hunting for it. It's about 6 in every 1,000 pregnancies in Australia, so that's partly why that group of parents is so vocal. It's again serology, and again you can do an amniocentesis and PCR on amniotic fluid to confirm fetal infection. It is a pain in the backside to interpret serology, but you can have the positive IgG and IgM, positive IgG and a negative IgM past infection, a negative IgG and a negative IgM, they have had no infection, are susceptible, but that negative IgG or positive IgG married with a positive IgM means there may be infection, and you should retest in 2 to 4 weeks. And this kind of got jumbled up, sorry, it's in the wrong order. So that same parental group and then the Cerebral Palsy Alliance in Australia have spent a lot of time and effort making posters and campaigns about encouraging parents about good hygiene, and it's everything Ines was talking about before. So washing your hands, not sharing food, don't share the drink bottle, don't share the cup that the kids had, don't finish the food on your kid's plate, don't kiss your kid on the lips, don't wipe your kid's nose. All great, but any of us who've had kids will know, not highly practical, especially if your kid is unwell. So I tell all my patients all this sort of stuff, but I also say have some hand sanitizer around and get some help from your friends as much as you can. And please don't beat yourself up if you've eaten the last chip off your kid's plate and you forgot. It's okay. So coming back to you've got this equivocal result. What do I do now? Well, you repeat the test in 2 to 4 weeks, as we said. So if there's been seroconversion, so they've completely changed their serology or their IgG levels have risen, you can say that this person was infected, and probably recently. If there's been no change in the IgG levels and your IgM is positive, again, it's a possible recent infection. So what you should probably do there is look at avidity, and this is where I get confused. And basically, I'm going to put this on the slide, but the reality of what I do in real life is I pick up the phone and call my friend who's an ID consultant and say, can you please interpret these results for me? Because it is very difficult. And what they will often do is get on the phone to the lab, and they will actually start talking to the lab people themselves, because it is really difficult to interpret. So low avidity means recent infection, high avidity means further ago, longer ago infection. So if you then have someone who looks like they've had a recent infection, these are the ones that you have to start talking about what to do. And these are the figures we all learnt for our exams and then promptly forgot afterwards because it was really too confusing. But basically, if a mum seroconverts to CMV during pregnancy, there's a 50% chance she's going to transmit that infection to her baby. 10% of those babies you'll see changes during the pregnancy, 90% you won't. Of the ones that you do see, clearly and obviously it makes sense. If you're seeing changes on an ultrasound or something, then many of those babies are going to have long-term sequelae. And with CMV, those long-term sequelae are bad. Overall, the outcome, if a mum gets CMV and then the baby gets it as well, so you've done your amnio, it's positive on amniotic fluid, it's not a good outcome. So you're going to lose about 1/5 of those pregnancies. Of the pregnancies that stick around, you need to do serial fetal ultrasounds looking for that symptomatic congenital CMV. It is really, really difficult if you've got a seroconversion in mum and a positive amniotic fluid, but nothing on ultrasound. It's incredibly difficult to counsel those women about what to expect their baby will be like. So if you're, 90% will have nothing really show up on their ultrasound initially, but 10% of those babies are going to have some very, very serious long-term problems. And it's really difficult to tell a woman, are you one of those 10% or not? So once you do see ultrasound findings, yes, you can be a little bit more specific about what the future might look for that baby, but those take many weeks to manifest. And so it's really difficult to give advice. And those of us who see lots of patients and have seen women with CMV, we would all include termination of pregnancy as a conversation, particularly if CMV has been an early infection in early pregnancy. And that's because early infection is associated with the really bad neurological outcomes, and late infection is much more associated with the visceral outcomes. So neurological, sensory neural hearing loss, microcephaly seizures, intellectual disability. So very significant outcomes. I get asked sometimes about, well, I've heard about getting, what's the word? I can't remember, but getting your CMV comes back again. Reinfection. Thank you. Infection, my brain stopped. It's time to stop talking. Less than 1% risk of transmission, less than 1% chance of having any problems with your baby. So unfortunately, if you are that 1% who has congenital CMV, again, there's a 10% chance of bad outcomes for your baby. But it is much, much, much less worrying than primary CMV in women. So difficult to prevent, difficult to test for and understand the serology, difficult to advise on in the absence of gross abnormalities on ultrasound, an all-round difficult condition, CMV.
Thanks, Vicky. I've just got a few questions from the participants. The first one is acyclovir versus famciclovir. We tend to use acyclovir, but as some of you notice, it's a B3, where famciclovir apparently is a B1. I didn't know that. So why do we use acyclovir? I suppose it's because...
So I don't know. I'm just going to turn the light on while we're talking.
Yeah.
I'm not quite sure. I think it's historical, and I'm not quite sure whether if you rang an ID consultant nowadays, they would give you advice that's not on the written guidelines and would use something more modern. But the written guidelines are still saying acyclovir.
And Jonathan's got a question, I think, that probably gets to the heart of it, but, it's one of the difficult parts of being a GP is the sort of undifferentiated illness. You get somebody who comes in with a cold and they're pregnant. You can't do the gamut of tests on everyone because you'd be doing the gamut of tests on everyone in every pregnancy, because it's almost invariable that a woman will get some sort of non-specific cold or upper respiratory tract during their pregnancy. What would your red flags be, Vicky, to I've actually got to investigate this woman for CMV or parvo?
So I think, like we talked about before, occupational exposure. So, you know, the childcare workers, the paediatricians, and I don't know what, I can only put it down to really good hand hygiene, but I'm yet to see a paediatrician who is immune to parvovirus. I do not understand. They all fall in the 40% susceptible category. It must be their good hand hygiene. So occupational exposure or exposure with children. You know, so if a woman walks in and says, my kid has been really unwell with high fevers and now I've got a runny nose, I know it's still very likely to be a bog standard viral ERTI, but I think if you don't know their serology to start with, I think it's worth running it. And this is precisely why I do a parvo at the beginning of pregnancy, because it's done and dusted for most women. And then I think other red flags for me would be a true fever. So, you know, it is actually really unusual to get a fever. And it's what really set COVID apart was actually people genuinely had a proper fever, not just I feel a bit hot and sweaty, genuinely had a fever. So I think if someone's genuinely got a fever, and whether that's a good omen, a good marker or red flag to use or not, I think that's a sign that's probably something that's got a name attached to it. So I go looking for things in those women.
Or a rash, I suppose.
Or a rash. Yeah, that's exactly what I was going to say. So, and a rash. What about you, Rach? Do you think that there's anything else that you'd add? Because it is hard. I mean, we do see women with a runny nose or a sore throat often.
I think part of the problem with both CMV and parvo is they tend to be mild illnesses in adults, and often even mild illness, not so much parvo, but CMV is often a mild illness in children, and just one of the many things they get from childcare. Like you, Vicky, I do serology on everyone when I first see them, because I think it helps with counselling. I think people like to know. It helps manage their level of risk and their anxiety, and it makes our lives so much easier if they are exposed. I think CMV commonly causes abnormalities of liver function, so that would be something that would make me more likely to test for CMV. But the parvo is usually because GPs and childcare centres and kindergartens and schools are really switched on about it, and they tell anyone whose child is diagnosed that they should tell everyone they know who's pregnant. So that's usually
a nice sign up at the door. Often a nice sign up at the door when you arrive. So just a few other questions, and this is a really good one, is, you know, does EBV have the same sorts of fetal consequences as CMV? Do you know?
No, it doesn't.
And the other thing is, I think I know the answer to this, but I'll see if it's correct, is the risk of rubella infection in pregnant women with a low level immunity. I don't think there's been any transfer of rubella in Australia in the last 5 or so years, but you can get it from overseas.
Correct. That's absolutely right. And that's probably the group that we if we're going to seed them, we're going to seed in them. And I would say the other thing is, speaking to Michelle Giles, again, our ID consultant, is the serology for rubella is not directly correlatable to how susceptible someone is. So, and I'm sure as GPs, you'll all know that there are those people that you can vaccinate and vaccinate and vaccinate and vaccinate, and they never seem to show evidence of seroconverting. So Michelle says, you know, we can't rely on it, but you could almost assume those women probably are immune, actually.
And so, we do that for varicella, don't we? We say
right.
you need to immunisation, often don't convert.
So I think you don't need to be quite as worried about low levels and exposure.
Yeah.
But I think it's just more of a red flag to revaccinate postpartum.
And I mean, I don't think we'll answer this question, but it's an interesting one, which is Joanne was asking, you know, if CMV serology is so difficult to interpret, could it be something that people consider prenatally, so that they actually have their so they know if the CMV serology has changed?
I don't think it gets you, but I don't think it gets you out of the difficulties at the time of it.
And we don't know how it might change in pregnancy as well, as a function of pregnancy.
And there's no vaccination. So knowing pre-pregnancy or early pregnancy makes no difference.
Thank you.
I will stop sharing. Thank you so much for everybody for your attention.
That's been so valuable. It was just wonderful. And, I mean, we could have heard about that, I think, for the next 3 hours, but it was great, Vicky. Thank you so much. And it's so lovely to hear that the burden of illness on women and children has actually been so much more ameliorated because of the variation in Omicron, and presumably because of background immunity as a result of widespread vaccination as well.
And a big thank you to all the GPs, actually, because we don't vaccinate at the Women's, and so it's a bugbear of mine and Rachel's, but And so we've pushed people back to the community for their vaccinations, and that burden has fallen on GPs. So a big thank you from all of us for getting our patients vaccinated, because it's made a huge difference to work in the hospitals.
And from my point of view, thank you so much, Vicky, for your enthusiasm of standing up those COVID awards in such a short time period. It was just so effective. It was just so wonderful to see you rally the troops and get everything done. And I think that there is that sort of sense that everyone rallied together in their various fields for the last 2 years. And, you know, although we're all pretty exhausted, I think we'll sort of need to be pretty pleased with what we've achieved. So thank you, Vicky. Now over to you, Rachel.
Thank you. I hope you can all see that. So my topic this evening is third trimester problems or issues of the third trimester, which is a pretty broad remit. So this is necessarily a bit of a cook's tour through all the things I thought were important in the third trimester. I know, having looked at the list of attendees, we have a lot of really experienced shared care practitioners here. So I apologise if I'm teaching you to suck eggs. I'll try and keep it punchy and practical. I've deliberately chosen not to go through a whole lot of research and studies so that we can cover more ground. If anyone wants the references from which I'm drawing all of these conclusions, feel free to get in contact with me and I can point you in the right direction. Speaking of pointing you in the right direction, I'll again call your attention to the Health Pathways website, which has really sensible, practical, step-by-step what to do guides. We'll be talking about all of these red flags, plus a couple of others as third trimester problems. But if you're not registered for that, you will hopefully find it quite useful. The first thing I wanted to talk about was small for gestational age. This is something that we worry about a lot in pregnancy. Generally, we define it based on biometry, either on ultrasound biometry or birth weight of less than the 10th centile. And at 40 weeks, that's 2.9 kilograms, which is actually bigger, I think, than a lot of people think it's going to be. But for the purposes of assuming that you don't have an ultrasound to do serial biometry and you're not doing that regularly, for purposes of routine antenatal care, it's generally defined as the symphyseal height, fundal height, being more than 2 centimetres smaller than you'd expect it to be for the gestation. But as well as considering just the fundal height, I'd remind you that it's a good idea to look at the trajectory of growth and see babies that are not progressing as you would expect they would, or the fundal height is stalling. And there are a variety of graphs that you can plot these on. You can just get an idea from looking at the measurements that you've taken. And I think you guys have a great advantage compared to us in the public antenatal clinics, in that you're seeing the patients with more continuity than we can usually offer, or certainly at the women's anyway, which means it's the same person measuring the fundal height each time, which makes these measurements much more reliable. But you can see on the left here, a normal fundal height growth following the curve of the growth charts, whereas this one on the right shows plateauing of the growth, and even more worrying than this would be a static fundal height. There are broadly speaking, four reasons for babies to be smaller than average, or small for their gestational age. One of which just being that these babies are small, healthy babies. If we use the 10th centile as a cutoff, essentially what that means is 10% of the population are that size or smaller. So it may just be that we're picking up small, healthy babies. A clue sometimes, but not always, being the size of the parents. Chromosomal abnormalities, such as aneuploidies, Down syndrome, other genetic issues will often cause babies to be small for gestational age. And lots of the congenital infections, including CMV, will cause babies to be small. But the group that we really focus on, and the group that we're most interested in detecting, particularly in the third trimester, are the babies that are smaller than they should be, not growing as well as they should, because the placenta is not functioning normally. So uteroplacental insufficiency causing intrauterine growth restriction, which is really important because it is the leading cause of preventable fetal death in utero. And if we pick it up, we can monitor these babies appropriately, and we can time their delivery in order to strike the balance between maximising the safe gestation for the baby, but delivering before the baby's at risk. The other reason that we think it's really important to pick this up is that it is audited and reported by our friends at Safer Care Victoria and published widely. So we can see how well we're doing or not doing, as the case may be, as can all our patients. If you find a patient and you think the fundal, if you see a patient and you think the fundal height is smaller than it should be, or it's plateauing, the first thing to do is ask about movements. And if the patient reports decreased or absent movements, those patients need to come in for urgent obstetric review, either on our labour ward or in our emergency department. If that's not the case, though, you could give some thought to being able to organise and to arranging an ultrasound if you can organise one in a timely fashion. There are problems with access to good quality ultrasounds, and there's an out-of-pocket cost involved, so that might not be practical for you. Intrauterine growth restriction often goes hand in hand with preeclampsia. So in order to sort of stratify which patients need to be seen urgently in the emergency department and which patients you can send in for an expedited clinic review, it's a good idea to ask for any evidence or ask for any symptoms or look for any signs of preeclampsia. But these patients essentially all need to be referred into us urgently or semi-urgently for monitoring and to consider whether it is appropriate to do any testing or offer any testing, such as genetic testing or testing for infections. I thought as we worked through these, I'd try and close the loop a little bit and share what we do when the patients arrive at the women's or another tertiary hospital, because I certainly always find when I'm referring a patient on, having an idea of what's going to happen at the other end helps me counsel the patients. What we will do, of course, is monitor the baby and assess well-being in the short term, usually with a CTG. And we'll also assess the biophysical profile of the baby, looking at the amniotic fluid volume and the Doppler ultrasound measurements. We ask the woman to report reduced fetal movements, and we organise a growth scan. With growth scans, they all come with a plus or minus of about 10 to 15%. So when we're repeating growth scans, we always try very hard not to do them any closer together than 2 weeks apart. If you do growth scans too close together, you can't tell what's the plus or minus and what's real growth, or conversely real lack of growth. You can't see the signal for the noise. So while we'll certainly do lots of ultrasound monitoring more frequently, we tend not to do growth scans any more frequently than fortnightly. And if patients are asking you for growth scans more than fortnightly, it's a really good idea not to do them, because they will just confuse you or confuse everyone. We tend not to do growth scans after about 36 or 37 weeks, because that plus or minus just turns into too big a number. After 36 or 37 weeks, it often will come with plus or minus 500 grams, and it just ceases to be useful. Other testing we might do as appropriate or as desired by the patient, including things like genetic testing. And the other thing that we will do with these patients is come up with, as well as a plan for monitoring into the future, delivery planning. Because we're walking that line between trading off the benefits of that extra few days or extra week of gestation, as the case may be, versus the risk of leaving a baby in an environment that we're not 100% confident in and that we can't monitor 24/7. Where we do that depends a little bit on the degree of growth restriction and how worried we are and the monitoring, but it tends to be before 40 weeks, which is what this graph is all about. It's the patients who are still pregnant at 40 weeks and turn out to have been at the 10th centile or below, which are considered to be the ones we've missed. The indications for delivery essentially are any degree of fetal compromise obviously will deliver. If the babies stop growing on serial ultrasounds, we generally consider that there's very little to be gained by remaining in utero, and that's usually a trigger for delivery. And fetal maturity is also a trigger for maturity, a trigger for delivery, with 37 weeks being term, so being our kind of lower threshold, and certainly before 40 weeks, depending on how worried we are and how small the baby is and what the monitoring is telling us. But in general, we have a decreasing tolerance for risk as the gestation increases, and we have essentially no tolerance for risk beyond 39 weeks. I thought I'd also talk about, sorry.
I've just got a few questions. Michelle asks, are you aware of any practice software that actually has those sorts of percentile charts for unborn babies?
You can download. So certainly our electronic medical record at the Women's does it. I don't know. Jeannie doesn't do it, and I don't know about any other.
I don't think I use best practice. I have never seen it on best practice, but if anyone knows of anything, it'd be great to actually put that in the chat function. The other question was, I suppose, what's a timely fashion for a T3 ultrasound in the possible, small for gestational age? And that's going to depend on your index of suspicion. But I thought perhaps you could just sort of articulate what are the factors that you consider in thinking, well, do I need to do this tomorrow or the day after, or can I leave it a week or so?
I don't think you should leave it a week or so, but if you're worried about someone and you're referring them into their clinic and it's Vicky's clinic on a Wednesday and you find this on Thursday morning and the patient won't be seen until the following Thursday morning and there's not an indication for the patient to come into the emergency department or the birth suite before then, if you can practically organise a reasonable quality ultrasound scan and the patient can afford to pay that out of pocket cost, then that's going to make everything a little bit easier and may even reassure you that the baby in fact feels small, because often what you find on ultrasound and what you find on clinical examination don't necessarily correspond. Some people hide their babies better than others. So you may get a ultrasound saying that the baby's on the 50th centile. I would probably still send that baby in for review because not all ultrasounds are equal, but that might allow you to be a little bit less worried.
And certainly, as all the shared care providers would know, if you have any level of decreased fetal movement, that would mean sending the woman to the pregnancy day service that day. And if the pregnancy day service is closed, then the women's emergency care department, and a normal fetal Doppler ultrasound is not sufficient. The woman actually needs to be seen in hospital.
Yeah, absolutely. And those growth charts, though, there are lots that you can just download from the internet if you want to plot them yourself. A lot of them are kind of generic, and there are various ones that are adjusted for size of the parents and ethnicity, and it gets quite complicated. But I think what you want to see is not so much the actual level, but the growth along the appropriate angle. I thought I'd also mention large for gestational age, which I think actually is a harder problem to deal with than small for gestational age, because we're not as good at diagnosing it and it's much less clear what we should do with it. A fundus might be large for gestational age if the baby's big, but there are other causes, such as a big mother who will also have a large fundal height, although conversely often a very small baby, a fibroid uterus, or an increased amniotic fluid volume. So it's always very tempting to do an ultrasound to investigate that, which clarifies things. But you've got to remember when you're looking at an ultrasound, particularly of a big baby, that there is that 10 to 15% error. And that just means we're much better at estimating weight down the smaller end of the scale, because 10 to 15% error of a small baby is, in real terms, a smaller number of grams. Once you're getting up to a baby that's 4 kilograms, that 15% error is 600 grams. So basically what that ultrasound is saying is the baby is somewhere between 3.4 and 4.6 kilograms. So it becomes much less accurate. And even if we know down to the exact gram what size a baby is going to be, we don't have a good way of assessing which babies are going to fit through which pelvises. And I'm sure you've all seen small women have big babies and make it look easy, and big tall women who you think would have plenty of capacity in their pelvises have an obstructed labour with an average or even a small baby. Macrosomia is variably defined as above the 90th, the 95th or the 97th centile, which at 40 weeks is 4, 4.5 and 5 kilograms respectively. We're mostly focused on the issues around delivery for these babies, but it is important to remember that these large for gestational age babies are at increased risk related to their size or their macrosomia. Macrosomic babies are at risk despite their mode of delivery, both in utero and in the early postnatal period. But when we're considering delivery, our main considerations are we want to avoid traumatic labour and shoulder dystocia. We want to avoid a prolonged labour that culminates in an emergency caesarean, because everyone agrees that's the worst way to have a baby. And we also want to avoid the postpartum hemorrhages that come with difficult vaginal deliveries and prolonged labours and obstructed labours. It's not controversial that if the baby is thought to be bigger than 5 kilos, knowing that we don't always get that prediction right, but if our prediction is 5 kilos or more, it's not controversial that those patients should be offered a caesarean. In the diabetic population, that number moves down to 4.5 kilograms, because weight for weight, babies of diabetic women tend to be a bit chunkier. For everyone else, it's much less clear what to do. And the options are wait and see what happens, let nature take its course, offer an earlier induction, or offer delivery by caesarean. So generally, if when I'm in clinic, someone comes to ask me whether they should do an ultrasound for someone whose fundus is measuring a bit high, I generally say no, or I'll generally just send them over for an AFI to make sure it's not polyhydramnios. But I don't tend to do routine biometry unless the fundal height is really very big. When we have an ultrasound suggesting macrosomia, I think what I generally do is sit down with the woman and talk about the uncertainty of estimating the weight. And I'll often do the maths of 15% plus or minus the weight that the ultrasound has given us. But then I think this is a decision we have to make with the patients, because there are risks involved. And I discuss the risks of macrosomia, so an emergency caesarean for obstructed labour, a difficult birth resulting in trauma to the mother or the baby, including a shoulder dystocia, and the downsides potentially for the baby if we do decide to deliver earlier than 39 weeks with an elective induction. And we discuss those options with the patient and engage in shared decision-making, taking into account, obviously, the patient's, the woman's preferences and her priorities, and looking at the whole situation. If this is a tiny woman with an enormous husband and a very big baby on board, that would make me more likely to offer a caesarean. If the head's high and mobile at 40 weeks or 41 weeks, that would make me very pessimistic about the prospect of a vaginal delivery, and I would be considering a caesarean rather than an induction. Whereas if the head's well engaged, the patient labours spontaneously at 38 weeks and has an appetite to give it a go, I think that's much more reasonable. If a decision is made about to go ahead with a trial of labour and vaginal delivery, we generally will set some common sense parameters around that, like having somebody experienced in the room in case of a shoulder dystocia, having perhaps a lower threshold for proceeding with a caesarean if the labour is slow to progress or there are early signs of obstructed labour, and not attempting a difficult vaginal delivery, like a high forceps delivery or something like that.
Rachel, could I just ask, this question's from me, with regards to having a prima gravida with a high-headed term, a decently high-headed term, you check that the placenta's not in the way, have another look at the ultrasound result. And if that's the case, do you have an active discussion with the woman about the fact that she's got an increased risk of caesarean section, failure to progress, that sort of issue? And how do you quantify that?
Yeah, I think the data is really not clear. But for people who labour spontaneously in their first pregnancy, their risk of caesarean is around about 20%. For people with a high mobile head at term, particularly if they need an induction, their chance of a vaginal delivery is probably somewhere in the realm of about 10%. So it doesn't mean they won't have a vaginal delivery, and if they're keen to give it a try, I'm very supportive of that. We know that women of African descent...
Sorry, Rachel, I think you said 10%. So
10%, yeah, that's the number.
10% more.
No, 10% chance of a successful vaginal delivery.
Oh, sorry. Oh, wow. So it's a, wow. So
have a high mobile
chance.
head.
Wow.
And that's high mobile head.
And that's for prima gravidas, not for multis, basically.
Yes. Yeah. And that's for the heads that are high and mobile at 40 or 41 weeks. And the ones that don't labour and we try and induce have quite a high rate of a failed induction. We just can't get them into labour. That does mean that 10% will be successful, and some women don't mind those odds and are very motivated and keen to give it a try. And I'm very supportive of that with those same sort of common sense parameters. I think it's high at 40 weeks, not high at 37 weeks. And women of African descent have a tendency for the heads to engage a little bit later. So often if it's someone who's 38, 39 weeks of a Caucasian background and the head hasn't engaged, certainly in my private practice, I float the idea that maybe this isn't just to sort of sow that seed and start preparing them, sort of managing their expectations. I wouldn't be so worried about a woman of African descent at 38 weeks with a mobile head.
And is there any place for an ultrasound to see what the cord's like, to see if there's a, true knot in the cord or some reason that the head's not actually going down, it's not about pelvis and baby size?
We're not particularly good at picking which babies are held up by their cord. And that's often not something you can tell on ultrasound. I think the undiagnosed placenta previa is definitely something to think about. But sometimes when you try and induce these women and it doesn't work, or they labour and it doesn't work, then you do find not so much the true knots in the cord, but babies that have a combination of just a shortish cord and it's caught around a leg or something like that, and they just can't get down into the pelvis.
Thank you.
Moving on to decreased fetal movements, this is obviously one of our really big red flag symptoms, and it's a problem because it's a risk factor for fetal death in utero. When asked, 50% of women who have a stillbirth report that in the lead up to that, they experienced reduced fetal movement, sometimes up to 1 to 2 weeks beforehand. These are data that I think are a little bit sketchy because we have the human tendency to find reasons and patterns that don't exist. And there's obviously a fair bit of recall bias here. But it's a difficult issue because there's no really good way to monitor fetal movements. Lots of studies have been done looking at counting, and there was a large trial from 2018, the AFFIRM trial, which showed that there wasn't any benefit in a sort of more standardised approach to monitoring and a standardised response from the part of the hospital. But I think one thing that we take very seriously, we obviously take decreased fetal movements very seriously, but we also consider the interaction with small for gestational age intrauterine growth restriction, because in studies that have shown that decreased fetal movement is associated with adverse fetal outcomes, including stillbirth, growth restriction seems to be a major contributing factor. But the difficulty from everybody's point of view is that there's no clear distinction between normal and abnormal fetal movements. So it's really hard to reliably detect the babies that aren't moving. I don't know how helpful it is to ask women to talk about what they mean when they say the baby's movements are decreased. I think if they tell you the movements are decreased, you have to act on that regardless. People have looked at kick counting and apps to monitor kicks and that kind of thing, and they don't seem to work, and some of them have resulted in worse outcomes. Primarily, it's thought because they work on a threshold, so that once the patients reach a threshold, they then don't have to worry about movements for whatever the time period is, possibly the next day. But if you think about it, if your threshold is 20 movements and you have 20 movements before 8 o'clock in the morning and then no movements for the rest of the day, that's actually not reassuring. And it's also hard to know what the appropriate investigation is. So given all of that uncertainty, if somebody tells you the baby's not moving or the movements aren't normal or they're a little bit reduced, there's no good way of assessing that, and you really have no option other than to send them in for urgent assessment. As Inez said earlier, in pregnancy daycare or the emergency department or the birth suite, because there's no good way of unpacking it. It's usually a false alarm, and that's totally fine. Patients should still be congratulated for coming in. What I think we can all do that's helpful is have a fairly structured discussion about monitoring movements. And I thought I would share what I do with my patients. At 24 weeks, and I think you have this discussion with the patient and make sure that you document it for medical legal reasons. At 24 weeks, I tell them that I would expect them to feel gradually increasing movements or become more aware of movements between 24 and 28 weeks, and they should be feeling movements every day. And I give them a heads up that at 28 weeks, I'm going to ask them to be a bit more systematic about movements. When I see them again at 28 weeks, I tell them that there's no set number of movements that the baby has to do per day or per hour, that it's not particularly useful to count the movements, but we want to be sure that the baby's moving throughout the day. So I ask my patients to check in with the baby's movements across the course of the day, maybe 4 times a day, I suggest that they make it easy for themselves to fit in with their normal routine. So when they sit down for a coffee, when they have a lunch break at the end of the working day, when they're sitting on the couch in the evening watching telly, whatever's going to work, and just ask themselves if they felt the baby move in the last few hours. If the answer to that question is yes, I tell them not to overthink it. But if they sit down at lunchtime and think that they haven't noticed the baby move since breakfast, then they need to stop what they're doing, get rid of all the distractions, focus on it. And if they don't feel enough movements to be reassured over the next 15, 20 minutes, they need to come in to get it checked out. I tell them that they need to present at the time. The whole purpose of this is to avoid being so busy and distracted looking after your other kids and working and running your household or whatever it is that you're doing, and getting to the end of the day or even the end of a couple of days and not know whether the baby's moved or not. Reinforce that they should come in at the time that they're not feeling fetal movements, not say, oh, I've got an appointment at the women's on Friday, so I'll just wait till then. And I tell them that normal is normal for them. So not to worry about what their neighbour or their sister or their friend tells them they should be feeling. But if they think, if it is their impression that the movements aren't normal, then they trust that instinct and they come in. And if it turns out to be a false alarm, totally fine. It's true that the movements change a bit towards term as the baby gets bigger and runs out of room. So patients should be advised that although the movements may change in character to be more squirming on the spot rather than somersaults and cartwheels, they should still continue in frequency. And if they feel like the frequency is reduced, they need to come in. What we do when they come in is we congratulate the patient for coming in and we reinforce that your advice was correct in sending them in. And we try and look at the whole clinical picture, particularly whether there are other factors for stillbirth or whether we think the baby might be small. We will do a CTG to assess the baby and a biophysical profile, so the Doppler ultrasound and amniotic fluid volume on ultrasound, looking for the baby's movements, including breathing movements on ultrasound. And we will generally do biometry, either urgently or non-urgently, although generally not after 37 weeks. But if everything's okay and the baby goes home, the last thing we say to them as they leave is that they did the right thing to come in and that they need to come back if they have the same problem tomorrow or the next day. It can be quite difficult to know what to do with women who have on an ongoing basis reduced movements, or they have multiple presentations with reduced movements. Below 37 weeks, we try not to deliver. Providing everything, this is providing, of course, monitoring is reassuring, but those patients obviously require quite close monitoring and lots of education about when they need to come in. After 39 weeks, we have a pretty low threshold for induction. And between 37 and 39 weeks, it's a bit of a grey zone, and we'll consider the other risk factors and what else is going on. No discussion of the third trimester would be complete without oh, Inez, before I go on, any questions about reduced movements or?
No, I think you answered them all. Thanks.
No discussion about the third trimester would be complete without talking about hypertension and preeclampsia. I'm sure you don't need to, this is, I'm sure, very much revision, so we'll jump through it really quickly. But hypertension we define as a blood pressure greater or equal to 140/90. You may, as I was taught, you may have been, as I was taught, that it was also significant if patients had an increase of 30 millimetres of mercury over their baseline systolic blood pressure, or 15 above the diastolic, that was hypertension. We've moved away from that as a diagnostic tool now, as there's not really any evidence to support it. And for hypertension to be preeclampsia, you need some evidence of end organ dysfunction, commonly proteinuria, changes in the renal or hepatic function, thrombocytopenia, neuromuscular irritability, which includes symptoms like visual change or cognitive impairment, seizures and hyperreflexia and clonus, and placental dysfunction in the form of reduced fetal movements or babies not growing. Just to be confusing, you can have preeclampsia without high blood pressure, which is atypical preeclampsia, and keep in mind HELP syndrome, which is hemolysis, elevated liver enzymes and low platelets, which is a subset of severe preeclampsia. Gestational hypertension, previously known as pregnancy-induced hypertension, is hypertension that develops without any of those other signs of preeclampsia after 20 weeks, whereas chronic hypertension is either something that the patients enter the pregnancy with or was diagnosed before 20 weeks, and that can be essential or secondary to something else, as distinct from preeclampsia, which has one of those other features with it. However, preeclampsia is often superimposed on chronic hypertension, and gestational hypertension often evolves into preeclampsia. With either essential hypertension or gestational hypertension evolving into preeclampsia, the women at greatest risk are the women whose blood pressures are elevated earlier in pregnancy and who have higher levels of blood pressure or require more medication to control it. And all of these women are quite high risk for preeclampsia. Preeclampsia gets worse with time, although it can do that quite slowly, in a slow and grumbling fashion or a very quick fulminating fashion, and the only cure is delivery. If you see a patient with new onset hypertension, probably the most useful thing that any of us can do is recheck the blood pressure, preferably over a couple of hours, which I realise might be difficult to do in your setting, and that's something we can do in pregnancy daycare, to see whether it really is high or not. Ask about the symptoms and check for the signs of severe preeclampsia. Organise baseline investigations and make an assessment of fetal well-being, which is auscultating the fetal heart and asking about movements, because these things will determine for you whether these patients need to come in urgently to be seen in the emergency department or on the birth suite, or whether they can have an expedited clinic review. And people need to come in urgently, I'm sure it won't surprise you to hear, if they have severe hypertension, if they have any neurological signs, if their biochemistry is deranged, if they have significant proteinuria, if they have abdominal pain, particularly epigastric and right upper quadrant pain, and if there's any suspicion of fetal compromise. You'll find all of those triggers on the Health Pathways website. It might be appropriate to arrange a less urgent review, like a clinic review, if the blood pressure is borderline or only mildly elevated, if there aren't any of those markers of a more severe preeclampsia, and if the baby's moving well and appears well grown. We will use, and I'm sure you use, antihypertensive medications very widely. It's important to remember that treating blood pressure doesn't change the course of the underlying preeclampsia, which may still progress despite controlling the blood pressure. However, it does allow us to reduce the mother's risk of a complication of the blood pressure, so a cerebrovascular event like a stroke, and might, in the absence of any other reason for delivery, might then allow us to prolong the pregnancy, even if it's only by a few days or a few weeks, to give the baby the benefit of some extra gestation, or to buy us some time to give the baby steroids or transfer to the appropriate institution. The indications for delivery are uncontrolled hypertension, severe or escalating end organ dysfunction, fetal compromise, and neurological irritability, so hyperreflexia and clonus and other neurological signs. Fetal maturity is also an indication for delivery, given that this only gets worse with time and can only be cured by delivery, with the same sort of thresholds as the small for gestational age babies, in that 37 weeks we consider the baby mature. We would generally deliver these babies before 40 weeks, but where we intervene in that range will depend on how severe the underlying condition is. Oh. Don't know what happened there. Bear with me for a second. I did say I wasn't going to present any research, but I thought it might be interesting to talk about the PERT test, because you will see this used quite widely at the women's. You will see this on our discharge summaries, and I thought it might be helpful to know how it guides our management. PERT is the preeclampsia ratio. Did you want to interrupt there?
Yeah, Rachel, I just wanted to know, do you know if it's available in the community?
It's not.
All right, thank you.
It's not, but used quite widely at the women's. This is a ratio of S-FLT, which is a tyrosine kinase that increases in women who have preeclampsia, to the placental growth factor, which decreases in preeclampsia. So as S-FLT increases and placental growth factor decreases, the numerical value of the PERT will rise. And it's a useful test because the PERT rises often days or weeks before women develop signs and symptoms of preeclampsia, and predicts subsequent development of preeclampsia, and the higher the PERT, the higher the risk. This is primarily a research tool. There is emerging evidence, but at the moment it's limited to tertiary centres in a research context. But we use it quite widely at the Women's, and I suspect you'll see it on discharge summaries of patients who come through pregnancy daycare. So I thought it might be a useful thing to talk about. Its use is based on studies such as this one, which our own Professor Brennecke was involved in, which found that if the PERT is less than 38, preeclampsia is very unlikely, with a really strong negative predictive value of 99% in the next week and 94% over the next 4 weeks. A positive PERT is a little bit less useful. It increases the risk of preeclampsia or predicts preeclampsia with a positive predictive value of 37% over the next 4 weeks. Those numbers look really, so it's much more useful to have a low PERT than a high PERT. Those numbers look really impressive. This was a fairly small study of about 1,000 women, and that's the limiting factor at the moment, is the small volume of data that we have. But it's led to the development of algorithms like this one that we use at the Women's. I don't propose to go through this with you in any great detail. I don't think you really need to know it, except to see that the level of the PERT and the gestation at which it's elevated guides our future management and our frequency of monitoring. Having said that, the indications for delivery are unchanged by the PERT results, so we wouldn't not treat someone or deliver someone who met our criteria for delivery if their PERT was low. We would still diagnose them with preeclampsia. A PERT alone is not an indication for anything and doesn't diagnose preeclampsia, it just identifies women at risk. A low PERT, though, is useful in that it sometimes provides us with a bit of reassurance to consider prolonging a pregnancy, at least for a week or 2 weeks, in a patient whose high blood pressure is controlled and doesn't have any other indications for delivery. It might mean that we'd push to 38 or 39 weeks in that woman where previously we would have delivered at 37.
One of the things that's quite relevant for general practice, Rachel, is the increasing offering of early screening tests for preeclampsia, and they often come with a cost. And I was just wondering, question from Barb, I think, which is really relevant, which is, you know, what do you think about them? Do you think they have a place? How would they change what you do?
I actually, so the one that you can get along with the combined first trimester screening, I personally don't use. I don't find it particularly useful above and beyond just clinical risk factors. And I'm not sure the data really supports its very widespread use. But I think that that's a luxury that we can afford in a private practice where we see patients much more frequently and see them intensively and have the ability to monitor much more closely. I think if there is a place, it's in primary gravidas only, but I think it's limited.
And if you do, because increasingly they do come back with a result. If it comes back as a reasonably high risk result, would you put the woman on low dose aspirin in that circumstance?
Yes, yes, but I'm not convinced it picks up a whole lot more women than clinical risk factors.
So the idea perhaps is if it's a high risk, you'd put them on either 100 to 150 milligrams of aspirin at night and try to start that before 16 weeks.
Yes, absolutely. And monitor those women a bit more closely.
Yeah, watch them. Maybe do an extra growth and wellbeing scan at 32, 36 weeks. That sort of stuff.
Yeah. But in a private practice setting, it doesn't add a whole lot. But I think maybe in particularly as we're getting more and more stingy with the number of visits in the public system, there may be a role for perhaps primary gravidas.
Thank you.
Not really well supported by evidence. So cholestasis of pregnancy, which is a nasty and confusing disease. It's pruritus in the absence of a rash in conjunction with abnormalities of liver function or raised bile acids, with that raised bile acids really being the pathognomonic feature, but you can make the diagnosis without that. You've no doubt seen people with cholestasis and seen how distressing it is. It's a generalised pruritus that includes the palms and soles, not as a lot of patients who've been Googling itchy palms will come in and say they have just an itch on their palms, or their soles. That's not cholestasis, it's whole body, but in in contrast to lots of other forms of pruritus, also involves the palms and soles. It's an intense pruritus that's often worse at night, often disrupts sleep, and these patients are often quite distressed with their level of itch. The risks of cholestasis of pregnancy is associated with risk of stillbirth, although that picture is not entirely clear, as we'll talk about in a moment. And if maternal hepatic function is significantly affected, or vitamin K malabsorption is significant, can cause a maternal coagulopathy. The risk of FDIU in patients with cholestasis is not well defined. It seems very likely that it's elevated above the general population, although newer evidence is suggesting it's less elevated than we have historically thought, less elevated than I was taught when I was training. It seems that the risk is related to the total exposure of bile acids. So the higher the level of the bile acids and the longer the earlier they're raised, the greater the risk. Unfortunately, there is no treatment or program of monitoring that has ever been demonstrated to reduce the risk of FDIU. And when it happens, it tends to be a sudden event, and it's not preceded by the things that we often rely on to predict FDIU is imminent, like the baby's not moving, or there being any ultrasound evidence of placental dysfunction, like the baby not growing, oligohydramnios, or abnormal Dopplers. I should say, with the risk of FDIU, part of the problem with this is just numbers. This is not a terribly common condition, and FDIU, even at increased risk, remains a relatively rare occurrence. So it's very hard to power a study adequately to define this, which is the problem. And the studies that show that the risk of FDIU is not as high as we previously thought it was are well-conducted studies that have relatively small numbers of women in them. But if you see a woman that you think might have cholestasis, consider other causes of pruritus, and you guys are probably in a much better position than I am to assess that. Examine for a rash, because cholecystitis generally doesn't have a rash, although bear in mind that there may be quite a lot of artifact from intense scratching, so excoriation. And the rashes you might see in pregnancy, as well as the urticarias and eczemas and other dermatoses that you guys will be all over. Polymorphic eruption of pregnancy, which is what PUP is now known as, and pemphigus gestationis, which is a vesicular rash that's also very itchy. These patients should have their LFTs and bile acids checked and be seen quickly by us. That usually doesn't mean, unless there's evidence of fetal compromise, then obviously you should send them straight into the hospital. Otherwise, review in clinic within a week is probably appropriate. But you might start some symptomatic treatment because these patients are very distressed.
So just to clarify, Rachel, just urgent referral to us if the LFTs and bile acids and all bile acids are abnormal.
Yep, and more particularly if you're worried about fetal compromise.
Oh,
so if you think the baby's not moving. What will we do when they get to us? We will, despite there being no evidence of benefit, we will monitor the baby and keep these patients under regular review. We will treat them symptomatically with ursodeoxycholic acid if you haven't already done that. That definitely reduces pruritus and improves people's quality of life. It makes the LFTs and the bile acid levels look much better, but it hasn't been proven to improve fetal outcome. That's absence of evidence, not evidence of absence. It is, I think, probably a numbers issue. And the fact that we know that higher bile acids convey greater risk, probably extrapolate from that, or we extrapolate from that if we can bring down the bile acids, that will hopefully make a difference. But there is a possibility that it's like the blood pressure and preeclampsia thing, that it makes although you can make the blood pressure look better, it doesn't change the course of the preeclampsia. We often use antihistamines for symptomatic treatment, particularly sedating antihistamines at night to allow these women to sleep, because they're often quite sleep deprived by the time the diagnosis is made. And we ask women to be mindful of the baby's moving. Delivery for cholestasis is controversial. I was taught that they should be delivered at 37 weeks at the latest. However, that we have moved away from that somewhat because early delivery is not proven to improve the fetal outcome. I think there is a role for early delivery in terms of just relieving the symptoms that these women have, because as I said, they are very distressed. We have traditionally had a sort of default position of delivering at 37 weeks. There are some studies that suggest that at least half of the FDIUs occurred before 37 weeks, although I was looking at one of these the other day, and this study was 14 cases. So it is still the same problem of small numbers. And when we deliver babies at 37 weeks or earlier even, we need to think about the potential downsides of a late preterm or early term delivery in terms of neurological development and long-term cognitive performance. So it's not straightforward. The role for vitamin K, again, seemed to be very well established when I was studying for my exams, but now we have moved away from that. And we think there's probably no real benefit for it unless there's a significant loss of hepatic synthetic function or an obvious change in the coags. But obviously the baby should still get routine vitamin K.
Just a few questions, Rachel. From what gestation do you start thinking about cholestasis?
Look, typically it's after 24 weeks. Yeah. However, we know that some women develop cholestasis on the oral contraceptive pill. I've seen people come into pregnancy with cholestasis, and some patients with pre-existing underlying liver disease, like the ABCB4 disease, will have cholestasis outside of pregnancy that then tends to get worse in pregnancy.
And in my experience, if somebody's got chronic hepatitis B or hepatitis C, then that's greatly elevated. The other question from me was that if somebody's had cholestasis in a previous pregnancy, does that change your routine surveillance for LFTs and bile acids, or do you just wait to see if there's symptomatology? And the second part is, what's the recurrence rate?
The recurrence rate is high, but it's not 100%. So most people who've had cholestasis in a previous pregnancy get it again, like most people who've had gestational diabetes get it again, but not everyone. I don't know that there's any evidence for this. I would usually start monitoring the LFTs a bit before they got sick last time, but I've never seen any good evidence or a guideline to support that.
The other thing that a few people have raised, and I've found as well, is the issue about bile acids in the community. It can actually take quite a long time. And firstly, the issue is, I suppose, traditionally we're supposed to do fasting bile acids. Do you really worry about that? Because that can make it quite difficult. And then secondly, do you wait for the bile acids? I would suggest that if you've got abnormal LFTs, you don't wait for the bile acids. But
no, I definitely don't wait for the bile acids, and I don't usually for my first test do a fasting bile acid. We have the same problem in the hospital. The assays only run once a week. So if you manage to just jag it and get the day that the assays run, you get a result straight away, and otherwise it's a week's wait. And sometimes even seems to be longer. I think you can start URSO for symptomatic treatment and start offering CTGs while waiting for that result to come back, even before you see the LFTs. Because if everything comes back as normal, that you can always stop the URSO. It's not a one-way street, and there doesn't seem to be much of a downside for being on URSO.
And somebody's asked about which antihistamine. To be quite honest, I usually say just try, ask the pharmacist. They're actually much more likely to know what the safe antihistamine is in pregnancy. But there's also the Royal Women's Hospital pharmacy line to call. But Rachel, what's your thought about that?
Antihistamines are fine in pregnancy, so they can use Claritine or Telfast or Zyrtec, whatever they normally take during the day, and either doxylamine or Phenergan at night. I think doxylamine's better. I think you get more sleep with doxylamine than Phenergan, personally, having watched my patients take both, but I'm not sure it makes much of a difference.
And how long do you have to follow up liver function tests postnatally, or do you just know that they will settle down to normal? And how long, if you do follow them up, how long do you follow them up for?
It depends on how bad they've been, but usually I would check them unless they've been significantly deranged. I just check them again when I see the patients at 6 weeks. If patients have had much more significant liver dysfunction, then I might check it a little bit earlier. And these patients need to be warned that if they go on the oral contraceptive pill, they may have the same problem. So if they are to start the pill in the future, then they should you should check their LFTs after a couple of weeks on the pill.
So Gillian's asked if we should start URSO in the community. My feeling about that is it's actually, you're hiding the symptomatology. This is actually about referring to hospital. But Rachel, what's your about?
I think they have to be referred to hospital. I always try and get them onto URSO early because they're so distressed. If they've got good going cholestasis, they're so uncomfortable and so itchy, and they all say they'd rather be in pain than as itchy as they are. And sometimes by the time you see these women, they haven't slept for days. I don't think that, so long as, I think it's important that you refer them in. I don't think it really matters if they're not coming in to see us for another 2 or 3 days and you start them on URSO, then I think you might significantly improve their quality of life.
Thanks.
I thought I'd come up with, so they're all the red flags that are on the website, and I've hopefully got enough time to talk about a couple of other things and to answer any other questions you might have. I thought I'd talk about some of the couple of the issues that plague us in the antenatal clinic at the Women's. One is a request for a 3rd trimester growth scan. We don't offer that to low risk women at the Women's unless there's some sort of clinical indicator. But it is widely practiced in the public sector. So I always feel like a bit of a hypocrite when I tell patients that they don't need a growth scan and that we're not going to offer them one in the public hospital. But realistically, there's a capacity issue that we just can't accommodate that. What we do know, but you know, it's out there, it's on the blogs, their friends know what centiles their babies were, so they want to know what centile their baby is as well. So we often get quite a lot of pushback from patients when we decline to organise a scan. We do know, however, that there is limited benefit of a single scan because it's not terribly helpful to know that a baby's on the 50th centile unless you know whether it's stably on the 50th centile or it's going up or going down. And for a baby on the 50th centile, you don't know whether that's where that baby's meant to be, or it's a baby on the 20th centile that's macrosomic for its growth potential, or a baby that ought to be on the 80th centile and is not growing well. So that's where the trajectory of growth with serial scans is really important. And that's what you should, if you're worried about somebody's growth, that's really what they need. If they've got a risk factor for growth restriction, for example, having had a previous small baby or a marginal insertion of a placenta or combined placental mosaicism or something like that, those people need serial scans. A single scan isn't helpful. As we've talked about a little bit before, there is an increasing margin of error as gestation increases and as the size of the baby increases. More significantly, there's an enormous range of experience and enthusiasm and expertise for obstetric growth scans in external ultrasound providers, and an enormous range of how accurate they are. And it's very hard to arrange a low or no cost scan, and generally the better quality scans are more expensive. In an ideal world though, I think it probably is best practice to limit third trimester scans to clinically indicated scans with people who are good at doing them. But I'd be happy to hear any comments or opinions on that.
I'm glad you answered that question because it came up a few times.
The other thing that we get quite a lot, and your patients may be wanting to talk to you about, is a request for elective induction. There is, as lots of the patients know, an accumulating evidence of benefit of routine induction at 39 weeks or starting at 39 weeks. Most of the patients won't have actually read the ARRIVE trial or the 2018 Cochrane review, but they've read other people commenting on them, or they're on their blogs, or their friends are being induced. And we are certainly pretty liberal with inductions in the private sector. Crunching all the numbers from those studies, we know that the number needed to treat to prevent one perinatal death is 426. And whether you consider that good use of resources or not, I guess, is a matter of judgment, matter for judgment. But it's you only need to do 28 inductions to prevent one caesarean. So there has emerged this trend in the wider population, certainly on social media, certainly among some groups of patients. It's out there, the patients know about it and they ask us about it. Our main problem at the Women's is that we don't have the capacity to offer people elective inductions. So that does lead to a fair bit of unhappiness with our patients wanting to be induced for various reasons, including being really uncomfortable, being anxious, childcare considerations. And I guess it's not that we're not sympathetic to those concerns. Of course we are. We're just in a big, busy hospital that operates close to capacity all the time and looks after a lot of very sick women and babies. We don't have the capacity to offer this, and I think the situation is probably the same in most other tertiary centres. So it might be something that if you're sending patients in to discuss that, you may wish to manage their expectations.
One question is the use of low-dose aspirin for previous small for gestational age when there has not been preeclampsia.
Yes, yes. A little bit like preeclampsia, it becomes, it's often a first pregnancy problem, and it's automatically less of a risk in the subsequent pregnancy. Or if it happens later in the pregnancy and is less severe. But it is essentially the only thing that you can do other than monitor the babies. So yeah, but people who've had a previous small baby, we would definitely recommend starting them on aspirin. The dose is a little bit contentious, somewhere between 75 and 150 milligrams. And apparently works better at night, I hear. I don't know why. Yeah, definitely. For reasons I don't understand, works better if you take it at night. And previously we've told people to take a 300 milligram aspirin and break it in half and have the other half the next night. But the last conference I went to said you can't do that because something happened to the other half of the aspirin, so you've got to get a new one the next night. But it is the only thing that helps. The idea is that it improves placentation, so it needs to be started certainly before 16 weeks. It seems to have its benefit. It doesn't work if you start it after 16 weeks. Probably does most of its job between 12 and 16 weeks. So ideally you start it before 12 weeks. And then obviously those women, the more important thing I think that you can do for those women as well is serial growth scans.
And the place for calcium supplementation in those women?
Less well established. I'm not terribly convinced by that research, including for preeclampsia. I don't know what you think, that although it is quite widely practiced at our hospital within our MFM unit. I don't know what you think, Vicky.
I'm not in the practice of prescribing calcium. I'm yet to be convinced by the research on that. I really haven't seen it make any spectacular outcomes. And just to remind everybody that the low-dose aspirin is really good at preventing the severe early onset preeclampsia. It probably doesn't make very much difference to the later onset preeclampsia. I mean, the great things for those women is it tends to come on later and be less severe next time anyway. There is a trial running looking at the use of adding in esomeprazole to low-dose aspirin, and that's looking promising for preventing late-term preeclampsia. But I've tried very hard to lean on the researchers who are doing it at the Women's and say, so should I start some of this? We couldn't possibly tell you at this point in time. Damn it. So I'm waiting for that study to be published. Just
now I'm going to pick your brains while you're here. About a year ago, 2 years ago, it's probably pre-COVID, there seemed to be a bit of a flavour for alpha-3 omega fatty acids to actually decrease the risk of preeclampsia. Did that actually end up being something that was good research, or what's your thoughts about that one?
No, I don't think it is. I think that's not compelling.
There was a bit of a flush for that at the time, wasn't there? Now this is I'm going to read this one out because I get this quite a lot, which is many women complain of leg cramps. And you give them, you check their ferret and make sure that that's okay. If it's not, you make sure they're on some iron supplementation. But I mean, is there any place for magnesium in those women, with leg cramps, or is it just, stretches at nights?
Yeah, no, there's no place for magnesium, and no place for calcium. Because those things are so important to be within such a narrow range physiologically, if you put more magnesium in, you'll just put more magnesium out. so it gives you diarrhea. And women who are genuinely hypocalcemic or magnesiemic have more significant problems than leg cramps generally. And the studies that are looking at calcium and magnesium in pregnancy haven't shown any great benefit. Quinine also doesn't have any great benefit. It used to be recommended that people have a gin and tonic, but we don't recommend that anymore. And if it works, I'm sure it was the gin. I just tell my patients that that is a normal pregnancy symptom. We don't really know why it happens. We don't have a cure for it. And in my personal experience, it was just better to get out of bed and stretch properly rather than try and do it in bed.
Yeah, and have a stretch before you go to bed. So I've just got a few more questions. I'm just random throw them at you both, Vicky and Rachel, if that's okay. Just the main antihypertensives that are used in pregnancy, but just for the everyone on the webinar, it's actually they'll be started at the hospital essentially. But
yeah,
methyl dopa, usually Aldomet.
I personally don't use a lot of Aldomet. I think it's a drug that, because it takes a while to come to a steady state, it's not very adjustable. It makes the patients feel terrible. I would generally use labetalol or nifedipine. What about you, Vix?
Yeah, labetalol is my go-to. I rarely use Aldomet nowadays. And nifedipine, I'm just a bit cautious of because in particularly, just keeping in mind that relationship Rachel was talking about with preeclampsia and growth restriction. So even in the absence of growth restriction, you have to assume some placental dysfunction. And nifedipine can, in some women, really precipitously drop the blood pressure. And we do rely on a bit of blood pressure to get that blood across the placenta to the baby. So I wouldn't bring nifedipine until we're on really big doses of labetalol already.
Is methyl, because I usually think it's methyl dopa, is that the same as Aldomet or no?
Yep.
Right. And the other one I was going to ask, which was surprised me the other day, I think I said that I was quite surprised by it, Vicky, is that there's actually reasonably good evidence for perineal massage in decreasing severe tears. Do you want to speak to that? Because I think that's something that would be, it's really interesting for GPs and for midwives to talk to women about antenatally.
So the evidence is there. It's predominantly a Cochrane review, so it is reasonably good evidence, but it's compiled evidence probably. So most of the trials are small, but the evidence would say that it does not really decrease the incidence of tearing, and I think that's a really important message to get across to patients, that essentially tearing, particularly with your first baby, is very, very common, 80 to 85% of women. And I explain to my private patients that's probably a normal part of having a baby. What we're trying to avoid is big tears, and big tears are 3rd and 4th degree tears. And we know at the women's, our 3rd degree tear rate is about 5% in women having their first baby. So it's not insignificant. So yes, that perineal massage does. And, again, patients will come in having heard of Epino. A colleague of mine and myself are preparing a little video thing that we're hoping to roll out to all of our patients through the Yellow Team. Don't listen, Rachel, don't take any good ideas from us. But we're going to run a little pilot study in Yellow Team because we think it's just so hard to fit it in, to have a really decent conversation about perineal antenatal management in amongst all the other things women are doing. So we wanted to just try and do it as a video package that they can look at in their own time. And we will talk about perineal massage, but the big question we're batting around about ourselves is we don't know what the long-term sequelae of perineal, so the right time to do it is from 34 weeks, if you believe the data. But I don't know, and I couldn't put my hand on my heart and tell you what the long-term sequelae of perineal massage is. So is it better to massage those tissues and stretch them and have less tearing at birth, but I don't know what the long-term outcome of stretched tissues is, versus just having a tear that is then stitched back together again at birth? So I'm always very cautious of data that tells us this is great and it prevents this, but we don't have any long-term follow-up data. And perineums are a problem for a long-term. Everything we're trying to avoid for women is long-term complications. Would you agree with that, Rachel? There's a bit of caution in how I'm approaching that.
Yeah, I agree. And I tend to think that the contribution of perineal massage to preventing tears is probably a fairly small contribution. And I think management of delivery of the head is much more important. and judicious use of episiotomies. I think are much more important than perineal massage.
The other thing, if we're talking about, I mean, certainly I'm getting this a lot in general practice over the last probably 6 to 12 months, is women with no risk factors for early, for premature labour, actually being told to actually express antenatally. And certainly I've actually found it really, often women can get quite distressed about it and can become quite obsessive about it. And, I just wonder if there's a lot of unintended consequences to this, and wonder where this evidence is, or where this practice is coming from. Is there any evidence for this?
So the DAME trial, which was done in diabetic women, and I think published in either the Lancet or the New England, basically showed that it's not dangerous. Was the ultimate finding of that trial. It was thought that the idea was that people would express colostrum to use for the diabetic women would express colostrum to use for their babies if their babies had hypos, and the concern was maybe that
caused premature
labour. The conclusion of that trial was that it didn't, although there was a trend towards earlier labour and more babies in the nursery in that group. But I think the thing that really struck me with that trial is the average amount of colostrum that women brought in with them, despite some of them expressing multiple times a day for weeks, was 5 mils, which is not enough for one top-up. And lots of women get nothing. And that, I think, is the biggest problem with this, is that they try and express, they don't get anything, and then they get, 0.3 mils or something, and then think that that means that they're not going to be able to breastfeed, or they're not going to have any colostrum. So I think that the women who get lots have lots of colostrum anyway, so they're not really going to need it. And for everybody else, it's not, I think, not a particularly useful.
And I actually think could really put them in a negative frame of mind for actually successful breastfeeding. So I think that there's potentially quite unintended consequences. And I suppose just to let you know, it's becoming quite pervasive.
It is.
And it's nice to hear, because often as a GP I'm saying, I just don't think that this is necessary, and
the lactation consultants at the Women's would say, remember, their trial is in diabetic women, and they would not therefore recommend rolling that out to everybody.
Great, thank you. I'll just see everyone saying that this was such a fantastic session, asking for the PowerPoints, asking for the video. So yes, the PowerPoints will be coming out in the next week or so, as will the video, and there'll be a video recording on the women's side, and I imagine also on the Western side, and perhaps the Northern and Mercy. But look, thank you so much, Rachel, and thank you so much, Vicky. It was a terrific session. I learned so much. And thank you also to Karen and Joe from Western for being here, and particularly to Yvonne and the rest of the North West Melbourne Primary Health Network. Now, everyone go off and have your dinner, and thank you very much for attending.
Thanks, everyone, for sticking around on a Wednesday night.
Yes, thank you very much, everyone.
Bye.
See ya.